There we go. So welcome to OIG 201, Insights into OIG's Past, Present, and Future Work. I'm James Canati, Senior Counselor for Health IT with the Department of Health and Human Services, Office of Inspector General. And I'm joined today by my colleague, Christy Grimm, who is the HHS OIG's Chief of Staff. Collectively, we have over 25 years with our office. Last year, we presented at the HIMSS Annual Conference with an introduction to OIG, OIG 101. And today's presentation is a follow-on to that. We know that the regulated industry has to decide where to target limited resources to ensure effective compliance. So today we're going to identify some strategic documents that OIG regularly publishes, explain our rationale behind those documents, compare and contrast the content of those documents, and then use some examples specific to our health IT portfolio to help you gain some insights through using the tools we're going to teach you about our enforcement and oversight priorities. So our hope is that with that insight, you'll be better able to target either your compliance efforts or your client's compliance efforts and leverage the tools that we're going to teach you today. We will save time at the end for questions and answers, so let's get through a couple of things. Here's Christy's beautiful picture. Here's mine. And neither of us have conflicts of interest that we, real or apparent, that we need to report. Our agenda today, we're going to start with the government disclaimer that you've probably heard ad nauseum this conference. We'll move in quickly to Christy taking over and discussing OIG's key strategic documents. And then I'll jump in, and again, using what Christy's taught us, we'll walk through some examples with our health IT portfolio to figure out the priorities, the OIG priorities for past, present, and future health IT work. Our learning objectives align pretty closely with our agenda, as you might imagine. So we're going to identify the key strategic publications, distinguish between them, and then again analyze them to help you gain some insight into our oversight and enforcement priorities in the health IT space. So I have to say, from the OIG perspective, it's always a little challenging to explain the HIMSS step relationship between our work and the value of health IT, because as an oversight agency, we really feel like all of our work can enhance each of the 5 kinds of value that health IT can bring to patients, healthcare providers, and communities. But for our presentation, we flagged the treatment and clinical step because our mission is to protect the integrity of HHS programs, but it's also to protect the health and welfare of program beneficiaries. So our focus today is about helping you be more efficient with your compliance, and compliance at the end of the day is really about achieving both of those goals, better program integrity and better health and welfare for program beneficiaries. So we really hope that by understanding how to read and analyze the OIG strategic documents, you'll be able to get a sense for where our priorities are and better target your limited compliance resources, and that at the end of the day, that will allow you and your clients to provide better care for patients. So here's our disclaimer. The views that Christy and I express today are our own and do not necessarily represent those of the OIG or any other government agency or department, and I'm sure Christy will tell you the views I express are certainly not her own. So take them with a grain of salt. And at this point, I'm going to turn things over to Christy to lead us in the discussion of our key strategic documents.
Okay. Good morning. Thanks for attending our session. This is our second year back at HIMSS, as James was saying. We're always very happy to come to HIMSS to pull back the curtain a little bit to explain how we go about planning for our work, how to access our information more readily, and answer any questions that you might have. Today's focus is to give you some insights into how you can review OIG's strategic documents to identify, pull out, and find what makes sense to apply to your own organizations. And a couple of years ago when we were at the Chicago HIMSS conference, we started to see that there was a little bit of misinformation and mythology sort of surrounding OIG's work and how we identify and prioritize our work, that every audit flows out of an investigation, or an audit does involve investigators showing up at an entity. So we decided that we wanted to come and talk to you all to sort of dissuade some of those myths. It is a myth that we respond by doing an audit or an investigation always by a complaint or referral. There is a strategy behind what we do in the documents that we're going to go through. We'll sort of lay out what that strategy is. To a large degree, you really can predict the direction that OIG is going to be heading and what topics it's taking on by taking a look at a couple of key documents. Everyone's just very busy, so these documents are meant to sort of save you a little time. So what do we mean by strategic publications? Oh, I'll take that. Throughout the year, OIG issues a variety of strategic documents alerting the department, Congress, and the public to our strategic priorities, our planned work, and where we see the biggest challenges to the effective and efficient operation of health and human service programs. We use these documents to lay out our vision and where we're going to focus our resources. So I would say there are 3 types of actions that you can anticipate seeing across each of our strategic documents. Items relating to preventing fraud, waste, and abuse from occurring, items related to detecting where there are problems, and then where necessary, our enforcement actions when problems arise. We seek to prevent problems. That is so core to our mission by informing policy through the recommendations that come out of our reports, by technical assistance that we provide to the department and to Congress, and issuing industry guidance or performing industry training.
Chrissy, if I could just real quick reflect on that last piece. Our website has a really good body of resources for those who are interested in compliance. It's actually under the Compliance tab, Compliance 101. So if you're new to this concept of oversight by OIG, if you're wondering why it might be relevant in the health IT space, I'd recommend you take a look at our website to check out some of those resources. There are videos, there are handouts, there's a lot of useful material there.
We've had a lot of helpful discussions with folks here at this conference that really do use our compliance guidance and our trainings to improve their own organizations, which makes us feel pretty good that they're getting use out of those investments. So again, prevent, detect, enforce. Our detection is highly reliant on our data analysis that we perform, and we do predictive modeling. Anything that we generate is sort of founded in data, trends, in vulnerabilities. And then when problems arise, we do sort of take steps to work with our law enforcement partners to enforce relevant laws. So why should you care about OIG and the work that we do? To start, OIG is responsible for ensuring the integrity of the over 100 programs that are managed by Health and Human Services and $1 trillion in spending each year. These programs include emergency preparedness, food safety, drug evaluation and research, and we even have some jurisdiction to be looking at bioterrorism preparedness. HHS programs touch the lives of every American, and our oversight responsibilities are for all of those programs that touch Americans. Most germane to you, we also have oversight for agencies that have programs or responsibilities related to health IT, such as meaningful use incentive and certification programs run by CMS and ONC, HIPAA privacy and security rules under the Office for Civil Rights, and approval for networked medical devices associated with FDA. What's also unique about our Inspector General's office and sort of distinguishes us from other OIGs is the amount of work that we do external to our department. Most OIGs do a lot of policing within their own borders, state OIG looking within the State Department. We go outside of HHS a lot to look externally at individuals and entities that receive HHS funds or that are involved in HHS programs, including hospitals, physicians, contractors, health information exchanges. We really sort of, our jurisdiction allows us to follow the programs and where the dollars are. So let's get sort of cracking on looking at some of our strategic publications. I'm going to walk through and sort of deconstruct our SemiAnnual Report to Congress, our SemiAnnual Work Plan, and our top management and performance challenges that are facing HHS. Starting with the SemiAnnual Report to Congress, every OIG in government is required on a 6-month basis to report on significant activities. We post these reports on our website in April and then again in November. The SAR includes significant problems, abuses, deficiencies, and investigative outcomes related to HHS programs and operations. So while the contents of the SAR are retrospective, they do include a few helpful signals. For instance, at the beginning of the SAR, you'll always see a letter from the Inspector General, which typically sort of foretells what you might be seeing in the semi-annual report that's coming out 6 months later. So it's a pretty contemporary view of what's happening. And then in the highlights section, if you don't have time to read the 75 to 100 pages of OIG's significant accomplishments, it does identify some sort of key themes, key vulnerabilities, and issues for which OIG is likely to continue investing its resources. And I think the big value of the semi-annual report is if you don't want to set up alerts for each and every sort of settlement, investigative, civil, criminal investigative outcome, you can check out the semi-annual report for a nice sort of digest of that information. Next, we're going to get into the work plan, and this is my personal sort of favorite document. When we released the document in 2012, it was downloaded within a couple of months over 100,000 times. The act of planning and deciding what work we take on is a very sort of dynamic and ongoing process. We add and we delete jobs all the time, but we publish our work plan currently twice a year. October, November, and then again in June. But because we know that stakeholders really sort of look to that to see where OIG is investing time and resources. I mean, there are entire conferences built around where oversight in HHS programs are headed. We're looking to release our work plan on an ongoing basis, to have a living work plan, and we're close to that. So I would expect by June, you are going to be able to check out at least once a month what we've added and what work has been sort of revised.
And Christy, just a quick note, you don't have to forget everything you're learning here today, even though the format is going to be a little bit different in the Living Work Plan. All the tips that Christy's going to teach you are going to be applicable to the format in the new version as well. So you can rest assured.
What's in the work plan? Typically, it's audits and evaluations and descriptions of that work. It also includes some investigative and legal work, but because that work is sort of largely reactive to sort of complaints and referrals, it doesn't have a lot of content on that, of course, but it really is a terrific reader's digest of where we're investing our resources. The content in the work plan is generally arranged by program area, Medicare, Medicaid, and then within that, specific topics of interest like harm caused to beneficiaries that are receiving care in skilled nursing facilities. So if you're sort of looking for your topic, James has a few tips on how you can sort of sort through the programs and issues to find what you're truly interested in. And I'm often asked, as it relates to work planning, how we get ideas for the work that we take on. It comes from a whole variety of sources. It can come from data mining, from some of the predictive modeling that we do. It can come from referrals. It can come from requests from Congress, from the department. It can come from follow-up to work that we've done in the past to see if there are improvements to the vulnerabilities that we've identified. So it can come from a whole sort of range of different places. Here, just very quickly, you'll see a page from our work plan which tells you what content is new, has been completed, is revised. Again, we're modifying our work all the time. It also indicates items that have been removed. So this is an actual page from our most recent publication of the work plan. So we remove items for a whole variety of reasons. The program changes, a new rule makes some of the issues irrelevant. And here I just want to say it is also a myth that OIG won't publish a report if we get in and are undertaking an inquiry and we find that things are working as expected. That's not a reason for us to cancel a report. We will put out reports saying that things are working well, but we have a very limited sort of budget where for that $1 trillion, we have 0.035% of our budget is our budget to perform those oversight responsibilities. So we do have to make some tough choices, and we are very committed to doing work that's relevant and timely. So we do remove items all the time. Okay, so now I'm going to get into how you can deconstruct our work plan, a specific work plan item, to sort of foretell what you might be seeing when the report comes out for those of you who might be sort of subject to an audit or an evaluation, or you're just interested in where our analysis is leading us. So here you see an example of a work plan item. James is going to get into some specific health IT items later, but let's deconstruct some of what you're seeing here. From the title, you'll see the what. In every work plan item, you're going to find a what, a when, a where, a why, a who. You know, I've often sort of heard from people that are coming on new to our organization say that this is sort of dense information, but there are a lot of insights here if you take a close look. So you'll see from this that the OIG plans to report on hospitals' use of inpatient and outpatient hospital stays under Medicare's 2 midnight rule. In the first couple of sentences, you'll see some background and the general why OIG is looking at this issue. We very much want to be taking on the right topics at the right time, at the right depth. So we always want to have a strong rationale for why we're looking at something. So in this instance, CMS introduced a new rule to address concerns about hospitals' use of inpatient and outpatient hospital stays. And you'll also see a little context here. We call it the criteria for what OIG is going to be measuring against. Again, that jurisdiction hook, why we're looking at something. So here, you're looking at doctors expect beneficiaries' care to last at least 2 midnights. Inpatient payment is appropriate, otherwise outpatient is, so you can expect that OIG is going to be sort of comparing what's actually happening against that criteria or that rule that CMS has established. So next you're going to see who OIG is looking at. We often get questions about you know, how we sample, whether it's a national sample, a specific sort of hospital, a state. From the work plan and from this item, you can see that we're looking at hospitals use, which means all hospitals use, not hospitals in a specific state or a single entity. So you can divine from this that it is a national sample that we'll be doing. You'll also see some insights about our methodology. Here we're reviewing hospital claims. So you're typically always able to see in a work plan item, you know, what data source we're going to be drawing from for our analysis. There are a couple other clues in the work plan write-up about what will eventually come out of the inquiry. For instance, at the bottom of each work plan, you'll see a unique identifying number. This one starts with OEI, which means it's coming from our Office of Evaluation and Inspections. From this, you know likely that it is going to be doing a couple things. Typically, those inquiries are national in scope. Typically, we're looking at efficiency and effectiveness types of issues, whether the program is operating as it's intended, and oftentimes, those reports produce recommendations for improvement for programs and policies. So you can usually tell that with a SIN number that starts with OEI. If you see a SIN number that starts with OAS, that means that it is from our Office of Audit Services, which tells you a couple of things as well. Usually the scope is a little bit more narrow, the sample size is a little bit more narrow. They're often looking at inappropriate payments, examining controls and whether they're working effectively. So again, you can tell a lot just by that sort of call number. So an evaluation like this one often examines some assumptions. The 2 midnight rule was supposed to ensure consistency across hospitals for billing inpatient versus outpatient stays. So that's assumption 1. Assumption 2, that it was supposed to reduce inappropriate short inpatient stays. And that assumption 3, that it was to correct adverse incentives adverse consequences of long outpatient stays because beneficiaries that don't have 3 inpatient stays in a hospital would not then qualify for skilled nursing facility care, a critically important benefit for our Medicare beneficiaries. So this report was actually published in December 2016, and we found sort of issues across all of those domains, inconsistencies across hospitals in the way that they were billing. We found that there were issues in reducing. We were looking at data in this instance, so we couldn't confirm that they were inappropriate, but we did see signals that there were issues in reductions in inappropriate short inpatient stays. And we also found that beneficiaries were paying a lot of out-of-pocket costs for long outpatient stays, and that it might interfere with their ability to then qualify for that skilled nursing facility stay. So the point in me raising this is to tell you that if you're looking at the work plan, you're going to be able to see sort of clues in the types of questions that we're going to be asking. It foretells the types of findings that will eventually come out of a report, not necessarily that we're going to find a problem, but that you'll have information about whether in fact there was an issue. So you'll know sort of the issues that we're looking at just by looking at the work plan. So next I'll move on to our top management and performance challenges document. So every OIG does something like this. So a top management and performance challenge is sort of, if you're familiar with GAO's high risk list, this is sort of our version of the high risk list. We are required to generate this analysis. It's included in the department's Health and Human Services annual financial report as an appendix, but it's also posted on our website. And this is sort of a very powerful driver for action for various stakeholders, for the department, for Congress, and it certainly is reflective of the work that we continue to invest in. The top management and performance challenges touch on critical HHS responsibilities, including ensuring access, ensuring quality services and benefits, whether they're exercising sound fiscal management, and safeguarding public health and enhancing cybersecurity. So it skips across all of these different areas. I'm not going to read all of these to you, but this is a listing of our most recent top management and performance challenges facing Health and Human Services. Within each of these, and James is going to talk about it a little bit more, there are elements related to health information technology. But you'll see in our TMCs, in some instances, we're talking about issues related to a specific program. So in the first one, we're identifying broadly some vulnerabilities in Medicare Part A and B, whereas in other sections, we're delving more deeply into the vulnerabilities and issue-specific, like quality of care and quality services delivered to our most vulnerable population. So it's a bit of a hybrid of programs and issues, but it's our hope, and it often is used as a roadmap for specific actions that we hope will be taken to improve HHS programs and vulnerabilities. So now and in terms of integrating the 3 documents, you are going to see, very reasonably a lot of repeated themes. So our top management challenges, if we're telling the department that there are issues in these programs, we should likely have some work dedicated to be looking at these issues. So the work plan is a good sort of reflection of the top management challenges. And then the semi-annual report will identify vulnerabilities that then we might be doing, say if there are a lot of investigations focused in an area, you're likely going to see some of that work then done by our evaluation or audit shop. So there is an integration across each of the 3 strategic documents. So with that, I'm going to hand it back to James, who will get into deconstructing some specific health IT pieces.
Thanks, Christy. So Christy's taught us how to kind of read through and use some of these materials. And as she said, I want to walk us through some examples so we can kind of refine this skill using our health IT portfolio. So first, though, I want to set things into some context. And I want to actually make an apology up front. Christy's very good at using the full names of terms. I've been in the government far too long, and I use a lot of acronyms. So just so we're all on the same page here, SemiAnnual Report, that's a SAR. If I say SAR, I'm talking about the SemiAnnual Report. Top Management and Performance Challenges, TMCs. I will try not to slip too quickly into acronyms, but in case it happens, I want to make sure we're all on the same page. So placing these in a little bit of context, the SemiAnnual Report to Congress is, as Christy said, largely retrospective, looking at our work for the preceding 6 months. So if you want to learn about what OIG has done in the health IT space recently, this is the place you come to look for recommendations, findings, legal and enforcement activities. The work plan includes our ongoing and planned work. So it's much more focused on the present and the near term, the near future. So if you want to know what we're doing right now, where we might be out auditing, what kinds of entities we might be looking at, then you want to look to the work plan. And the Top Management and Performance Challenges is what I consider our wraparound publication because it covers the past, the present, and the future. And as Christy mentioned, and we're going to get into a little bit, one of the specific TMCs is actually dedicated to health IT. So as a general note, in some of these documents, it's easier to find health IT related content than it is in others. We're always looking for ways to improve our materials from the user perspective, from the stakeholder perspective. As Christy mentioned, we're working on a living work plan. But I will make this ask, if you have thoughts or ideas as you get into our materials on how we can improve them from a user perspective, please share those. But for the time being, my approach is, when in doubt, I use the basic search function to find what I need on the health IT front. So let's start with the SemiAnnual Report. One of the first things you're going to get to in the SemiAnnual Report is the highlights section. And this is where, as the name suggests, we highlight certain areas and certain work that we want to elevate. So the current SAR, the current SemiAnnual Report, actually has an entire section dedicated to health IT. And it includes summaries of 2 recently issued reports. Beyond what's written here, so you can see that we've got 2 reports, one on hospitals and EHR contingency plans, and the other, which is a public report on wireless penetration testing of CMS. Beyond the information that appears here, we can glean some additional insight by considering where this sits in the document and what messages it might convey. So first, inclusion of health IT in the highlights section in and of itself, I think, reflects the importance of the topic of health IT to our organization. We don't have we don't have all topics listed here in the highlights, it's only select ones. So again, this reflects the prominence within OIG of the topic of health IT. And the second is that we issued more than 2 health IT related reports during this period. And the point I want to make here is, with respect to these 2 reports, these are the ones that, among all that important work, we thought should garner the most attention, or that you might need and want to be aware of. So just thinking about where this sits in the document, what messaging it might convey, it's helpful to understand where our priorities and focuses are. So the next thing you'll come to in the SemiAnnual Report is the table of contents. And show of hands here, who can tell me, look at the table of contents, where we'd find the health IT related material? Right, we can't. Unfortunately, this is one of those instances where the table of contents isn't super helpful from the health IT perspective. It's actually broken out by program area and more aligns, frankly, with our funding streams. So, and this is a great opportunity actually to kind of mention one important thing. Our funding streams, we have different streams, and they dictate what work we can and can't do. So about 80% of our budget has to be spent looking at Centers for Medicare and Medicaid Services, okay? So at Medicare and Medicaid. The other 20% is left to look at the other 100+ programs that HHS operates. So here we've broken out the SemiAnnual Report table of contents in terms of the CMS, public health, human services, and other related reviews. In this instance, this is where I go to the search function. So you can use general search terms like technology to kind of find relevant information. You can look for specific topics like EHRs or information security, or you can look by optive or stafftive. That's the agencies within the department we might be overseeing, like the Office for Civil Rights. So let's say we want to look a little bit more at that EHR contingency planning report. So we go into the body of the SemiAnnual Report, And this is what we're going to find. So a SAR write-up is similar to a work plan write-up in that there's the what, the why, the who, and an additional piece, the what we found, because this relates to completed work. So I want to walk through this one a little bit and kind of show you how I would read it to glean some information at a quick glance. So the first thing we're going to do is we're going to look at the identification number in the title to figure out what this is. So looking at the bottom, we know that it's an OEI report, Office of Evaluation and Inspections report, so that's an evaluation. And based on the title, it's an evaluation looking at EHR contingency plans. Next, we want to take a look at the background, and that's what we're going to find in the first paragraph. That's the why of this write-up. And if you look, we explain that disruptions, whether they're by natural disaster or technical malfunctions, can make EHRs unavailable, and that prior work that we've done have shown that hospitals were challenged based on the effects of Hurricane Sandy in accessing their EHRs. So when we combine those two things with the fact that we know that cybersecurity threats are on the rise, this was an important area for us to do some work. The who of this work is actually reflected in the next paragraph. In this instance, we're looking at the hospitals. So one thing to note here, in most instances, there are many ways to go about overseeing or looking at a particular issue. Usually we have a lot of options about how we're going to attack a particular issue. In this instance, we chose to look at what the hospitals were doing. We very easily could have looked at, because this relates to an OCR security rule, we could have looked at how OCR was implementing its program or overseeing its program related to that rule. But we make choices every day about how to approach an issue based on where we think we're going to have the most impact and what might be the most relevant information. So moving on to the what we found. This is the really important takeaway from the SAR that is different from the work plan. So this reflects completed work again. So here we found that almost all hospitals, and this is what you're going to see in the second paragraph, almost all hospitals reported having their EHR contingency plans, and most reported that the plans were addressing HIPAA requirements and recommended practices. So as Christy mentioned, sometimes we find good things and we report them out, and this is a really good example of that. Now, some of the semi-annual report write-ups are going to include recommendations. In fact, I'd say the majority of them, because a lot of our work, when we have a finding, we often make a recommendation about how to fix that finding. In this instance, we didn't have that. This really provided baseline information and supported prior OCR recommendations that we made. But when you're reading through a SAR, just remember that after we include our findings, you're likely to find some recommendations. And then one last tip here, if you want even more information and you want to read the underlying report, if you're accessing the semi-annual report on our website, the identification number at the bottom is actually a hyperlink, and it'll take you right to the full body of the report. So moving on to the work plan, this table of contents, as you can see, is a little more helpful in terms of identifying relevant areas to look at from the health IT perspective. So, for example, under the Centers for Medicare and Medicaid Services heading, we have an entire section focused on electronic health records. And under the other HHS reviews, we have an entire section focused on information security. So we can navigate to those sections and we can learn a lot about OIG's current and ongoing work in connection with those topics. But we can't stop there, because if we did, we'd miss other important health IT related work. For example, our work on network medical devices, which is actually focused on FDA's oversight and operations. And so that's actually going to be found in the middle orange box here under the public health reviews in the Food and Drug Administration section. So if we went to that section, we'd find actually two work plan items that relate to medical devices, network medical devices. And I want to compare and contrast these a little bit. So the first item, the one on the left, is, again, looking at the identification number in the title, is an evaluation looking at FDA's pre-market process. The why? Well, cybersecurity is increasingly important as more and more devices are getting connected to the networks and becoming vulnerable to threats that can impact functionality and safety. The who, as I mentioned, this is focused on FDA. And the how, this explains what we're going to do as part of this work. And we're going to examine FDA's approach to reviewing network medical device cybersecurity in their pre-market process.
James, how much of our work plan focuses on health IT specific issues?
So Christy likes to preempt me, and she's really interested in this number. So our work plan has about 200, a little over 200 discrete items. Some of those are various reviews, some are single reviews. But of the 200 items, there are about almost 24, I'd say, that relate to health IT. Some are health IT specific, like these two. Others are a little bit more tangential and focus purely on data, but in the OIG, we include that in our discussion of health IT. So you're talking about 10, 11% of our work plan, which may not sound like a lot, but again, if we're talking about 10 or 11% of our report work on overseeing over $1 trillion in spending, and a large portion of our health IT work actually isn't in the Medicare and Medicaid space, so it's a pretty big chunk of that 20% that's left over for us to do all the other oversight work. So, so that's the item on the left. The item on the right is, again, looking at our identification number in the title is an audit. It's a report out of our Office for Audit Services looking at FDA's response to medical device compromise. So we have some similarities between these two reports. The why is exactly the same. Cybersecurity is increasingly important as more and more devices are connected, and there's a potential threat to functionality and safety. And the who happens to be the same here too, the FDA. Now I see a couple of our FDA colleagues in the audience today, and I bet they feel like they're being a little targeted here, and that's not the intent. As I mentioned, we have a lot of options in how we're going to go about looking at particular issues, and in this instance, we wanted to have the most impact stepping into what for us is a relatively new space, and we thought we could do that by looking at the agency that touched a lot of devices rather than going and looking at a particular infusion pump, say. So again, we're going to be looking at the FDA. And in this instance, this audit, we're actually doing that by looking at FDA's plans and processes for timely communicating and addressing network medical device security compromises.
Why are we concerned about medical devices generally? Like what would you say is sort of a core potential vulnerability that we might be concerned with?
Well, so I think we know that more and more devices are connecting to the network, and again, that's exposing them to greater risk. At the end of the day, this work for me, and frankly, a large portion of our health IT portfolio, if not all of it, really comes down to patient safety. I think that there's a threat to patients, there's a risk, and we want to make sure that those risks are mitigated as much as possible, and the FDA has processes in place to consider those things, and so we're taking a look and evaluating that. But separate from this work, in my mind, most of our work really does come down to, or at least have a patient safety angle. And so I think it's critical for us to kind of be in that space. So beyond what's written here, we've broken these down. We've learned a decent amount about what these two different projects are going to be looking at. But what can we learn that's beyond what's written? And the first thing I'd say is that you're looking at two fairly coordinated work plan items, right? So this is the beginning of a body of work in a particular space. We've got something looking at the front end, the review process, and then the back end, what happens if there's a compromise, right? The second thing I'd say is that you can see that we're attacking this from a multidisciplinary approach. The evaluation on the left-hand side is focused on whether policies and procedures are working as they're intended. And then the audit on the right-hand side is looking at controls to make sure that they're in place and that they're working appropriately to ensure that bad things don't happen. I'd also flag that both of these are identified as having been revised, and I think that this demonstrates our ongoing effort to make sure that we're looking at the most relevant information and constantly refining our approach to things to ensure that we're targeting the right issues. What else can we learn about the work plan as a whole? Well, as we mentioned, 200 work plan items, about 20% or so, about 10% or so are related to health IT, so it's a big chunk of our portfolio. The other thing I would note is if you looked at work plans historically over the last few, you'd see a steady increase or rise in health IT related work. So you connect that with the SAR where we've highlighted this and the fact that we have a specific TMC on point, and the fact that we're here speaking at HIMSS, health IT and related issues are very much a priority for our organization. So speaking of top management and performance challenges or TMCs, let's walk through this a little bit. I would love to tell you that because we have a specific health IT related TMC, that's the only one you need to look at, but I think you'd be missing some things if you did. Health IT is from our organizational perspective, something that is cross-cutting. It impacts so many programs. And frankly, we have a discussion every year about whether we go the standalone route and have a specific health IT TMC, or whether we pull it apart and beef up the discussions in all of the other TMCs, because it's that integral to so many other issues. Over the past few years, we've had a standalone TMC, and that's what we're going to work through today. And I will say that if you have time to only read one TMC, this is a good one to start with, because from a health IT perspective, because it is the greatest concentration of our health IT information. And you get a really good sense for our view of the topic kind of as a whole. So let's walk through the top management and performance challenges for health information technology and the meaningful and secure exchange and use of electronic information. So the TMCs, all of them are broken out into different sections. And I want to walk through those, and we'll kind of talk through this one in particular. The first section is why this is a challenge. And this is where we explain kind of the magnitude of the issue or why it's important. And for example, this TMC, we highlight the fact that HHS maintains and uses an increasing amount of sensitive information. That complete, accurate, and timely information is important and critical to the efficient program operation within the department, and that the American healthcare system is increasingly relying on health IT and the electronic exchange and use of information. So that's why it's important. The next category or section is the key components to the challenge. And this is where we discuss specific vulnerabilities that we've identified or that we anticipate seeing to the extent we're talking about new programs. So for this TMC, we have three key components. The first one is ensuring privacy and security of information. And HHS has shown has to protect its own data and also consider data privacy and security when implementing policies and regarding health IT and electronic information that impacts the regulated industry. This is complicated by the rapid pace at which technology evolves, the continuing rise of the Internet of Things, and the expansion of mobile health. And it's also heightened by the fact that serious harms, including physical and financial harms, can result from threats to privacy and security. The second key component is improving the flow of complete, accurate, and timely information. And to leverage the growing amounts of data, the data has to flow, right? So there's a lot of information out there, but we talked a lot about it at this conference. We're always talking about data needs to be where it needs to be used, the right time, the right place, subject to appropriate privacy and security safeguards. But there are some factors that can limit the flow. Some of those factors are technical, like potentially the lack of interoperability, but some are behavioral, like information blocking. And I want to take just a moment or two to kind of step aside out of this portion of the presentation to focus on information blocking for a minute, because we've been talking about it a lot at this conference. I know there's some anxiety about some new authorities, and I think it's worth discussing quickly, at least. So the 21st Century Cures Act gave the Office of Inspector General new authorities to investigate and impose civil monetary penalties on certain parties for information blocking. We're currently reviewing those provisions and figuring out how to efficiently and effectively implement those new authorities, and we're coordinating closely with our colleagues in the department, including the Office for the National Coordinator. Right now, OIG has the ability to investigate certain allegations of information blocking under current and new authorities. But we don't expect to be imposing CMPs under the new 21st Century Cures authorities until after HHS issues regulations related to the definition of information blocking. So I wanted to make sure we were clear about that. I would be remiss, though, if I didn't remind people that the conduct underlying information blocking could be part of a larger scheme, and it could implicate existing authorities like the anti-kickback statute. So just because we don't anticipate imposing CMPs under the new 21st Century Cures authority until regulations are issued, doesn't mean there might not be situations that arise where it's appropriate for us to pursue that kind of conduct in connection with broader kickback schemes. We are very interested in learning more about the industry's perspective on information blocking. I had the opportunity to join one of my ONC colleagues yesterday for office hours at the ONC booth and heard from some attending about their thoughts and concerns related to information blocking. But I want to extend a general offer that if anybody has a particular perspective along the entire continuum of the industry, please reach out and share that with us. That will be very valuable. We really would appreciate that input, and it will help us think about some of the issues that we're tackling right now as we're thinking about how to implement these new authorities. So with that aside over and that plug for sharing some information with us if you have it, I do want to talk about the last key challenge, which is delivering on the promise of health IT. So HHS has invested a lot of money in health IT, over $35 billion in meaningful use incentive payments and other payments as well and grants. So the department has to ensure that those investments ultimately result in the anticipated outcomes that they'd hoped for. So for example, HHS has to make sure that the beneficial characteristics of EHRs that can lead to efficiency gains and can promote better care coordination aren't undermined by tools that can be used for fraud, like copy and paste functionality. And not to put too fine a point on this, but I want to be very clear. We've often been accused of taking the position that copy and paste is per se illegal, and that is not our position. Copy and paste can be a great efficiency tool. It just depends on how it's used. From our perspective, at the end of the day, the patient record has to reflect what was actually done. We're actually technology agnostic as it relates to that point. As long as the record reflects what was done, that's what we care about. Okay? So after the key components section, we actually move into a section focused on the progress the department's making. And this is where we talk about what the department has done to address some of the issues or challenges that we've identified. And then the last substantive section is focused on what needs to be done, where we see some room for further action by the department. Now, this is also the area where we'll flag places where we think we might be doing some work in the future. So in the current TMC, we identify interoperability across HHS systems and between providers and patients as one of the places where we might be doing some future work. And then lastly, each TMC includes a list of key OIG resources. If you're familiar with our TMCs and you'd looked at them recently before this most recent one, the lists were much, much longer. We worked pretty hard this last time to kind of consolidate and curate the list to make it a little bit shorter and to make sure that the reports were as timely as possible. But these are the reports that are relevant to or have helped inform our formation of the top management challenges. And the ones listed here are those that are specific to the Health IT TMC. So again, our mission relates very strongly to protecting the health and welfare of beneficiaries. Knowing how to read our materials, our documents, and leveraging the information in them can help people in the industry or your clients target limited compliance resources to more effectively ensure compliance with the regulations and laws, which we believe at the end of the day ultimately goes to the issue of patient safety. And our hope is that by taking what we shared with you today and leveraging them later, you'll be able to target your resources, and that will allow you and your organizations to provide better quality care in the long term. So with that, we've got some time for questions. And we also have a list of OIG resources here. If you'd like to check out our website, again, I mentioned there's a lot of good compliance information there. But now we're open for questions.
Hi, thank you very much for the presentation this morning. A couple of quick questions. With the change of administration, do you see the HEAT program as being supported? And also, a little bit curious as to why under the Indian Health Service Division, why the performance improvement measures were taken down for hospitals?
Do you want to handle the HEAT question?
Yeah, so the first part of her question had to do with the change in administration, if we anticipate a shift in investment in HEAT. So what HEAT is, for those of you who don't know, it's the Health Enforcement Prevention and Action Team. It is focused on targeting resources to attack Medicare, and it's over time evolved also into Medicaid fraud. And a key element of that are strike forces, where we work across federal entities and state entities and locals to really sort of build on the data that we have uncovered to target where there might be fraud and have sort of rapid enforcement for those that have committed fraud. So unfortunately, sort of fraud is always, I think, going to be a bit of an issue, and we have made terrific strides in the cities that have strike forces. We see that by the migration of some of the fraud going from DME to home health to other entities. So I wouldn't expect there to be a shift in investment in wanting to crack down on fraud. Your other question had to do with IHS with Indian Health Services and taking down a resource, and I'm not familiar with that, although we have somebody in this row who is from our evaluation shop who is responsible for a report on IHS. Aaron? Aaron, do you want to go to a mic? I can barely hear you.
Maybe we can take that offline and we have that conversation. We've got some other questions.
Thank you again for a very clear and concise presentation. My question is related to boundaries among the multiple federal agencies that are in all the space. I'm a CIO of a New York hospital. We've had 3 CMS Medicare audits. We have 1 OIG Medicaid audit. We have an OCR audit. and we're talking to NIST about their So my question is, one of your slides, you showed that security, HIPAA security, is actually a responsibility of OCR. Mm-hmm. So my very blunt question is, if it's their responsibility, why are you doing it? And the other related question is, medical devices are very important to us, but right before the session, there was a big session about NIST, about how they're developing a work plan next month on infusion pumps security. So are you, where are the boundaries amongst all these myriad agencies that seem to be coming at us hospitals with frequent audits?
Mm-hmm. Do you want to take the boundary piece or? So it's an excellent sort of question, and I completely understand the concern about there being many different entities in your hospitals, in your practices that seem to be sort of looking at similar types of issues. Another oversight entity, the Government Accountability Office, we do sort of coordinate with them so that we're not directly looking at the same thing with Medicare administrative contractors that are examining whether claims are paid appropriately. At least on the audit side, we do sort of share some sampling methodology. We don't always get it right, but we do try to sort of coordinate where possible so that it's not intrusive. With OCR, and James I'm sure will have some additional insights on this, sometimes we're looking at whether, I had said what differentiates us from other OIGs is we have a big emphasis on going outside of Health and Human Services to also look at, hospitals and providers. And then, we provide recommendations to improve where there are vulnerabilities and provider compliance training. We had a range of compliance training materials to help sort of educate practices on how to avoid the pitfalls of non-compliance, fraud, and abuse. But we do, we are aware that it seems like there's a lot of involvement with OCR. We're sometimes looking at whether OCR is meeting its mission, is meeting its obligations, is following its own guidance. So while we do have a lot of emphasis outside of HHS, sometimes we are policing our own borders and taking a look at whether, OCR is doing what it needs to do.
That's right, and not to put too fine a point on it, but as an oversight agency, it's our responsibility to ensure that the programs are being operated in an effective and efficient way, and then also that HHS dollars are being spent appropriately. And that's kind of the perspective we take, and that's why sometimes we're out in the industry looking at whether those payments were appropriate, and that's also other times while we're looking at how, as Christy said, maybe OCR is operating its program, whether they're doing so in an effective and efficient way.
But instances where there is, an audit, a RAC, a MAC, a GAO, we would like to hear about that so we can maybe look at the practice of sort of some of our samplings, because we're, again, we have 0.035% of $1 trillion, as we do want to make good choices in where we're making our investments. But I very much take your meaning and appreciate your point.
Hi, so my question kind of comes from I work at a health system in the analytics department, and we develop a lot of really neat tools and are integrated with quality and so on. We're being asked by the federal government to integrate more and more with ACOs, with CINs, and the quality measures that we're being held accountable for are very much dependent on their success, right? Mm-hmm. So 30-day measures, we haven't heard foreign change. So most of this stuff is out there. So it behooves us to help them as much as we can because we're on the hook for their performance, if that makes sense. Where I've really struggled is we can sometimes offer analytics-based tools to these groups at little to no cost because we've already developed them for our own people. And since we have so much skin in the game, it benefits us to give them these things. But we're very concerned about STAR clause and giving them things of value. And a lot of these places, they don't have the money to pay fair market value for some of the services or products that we've already developed and just want to give them access to. I'm wondering if the OIG, if you can give me some direction on documents that maybe I should read that would help give us an idea, or how you're working in tandem with as they continue to have us coordinate and overlap with each other, how you're adjusting maybe regulations that are actually somewhat preventative just by the letter of the law. Does that make sense?
Unfortunately for you, it does. I'm a recovering fraud and abuse attorney, so this is a space that is actually very near and dear to my heart. These are issues that we've been dealing with for some time. There are specific authorities in connection with certain Medicare and Medicaid new models, like the Medicare Shared Savings Program or CMMI models, where we've issued actual waivers of the fraud and abuse laws, certain fraud and abuse laws, to facilitate some of those relationships. We've also recently issued new safe harbors to the kickback statute that can facilitate some of those arrangements. We're aware of the tension or perceived tension sometimes, and we are constantly balancing preventing those things the laws were intended to prevent, the bad stuff, and not getting in the way of the good stuff. So each analysis, you mentioned the STAR clause. We don't actually administer the STAR clause, that's CMS, but we coordinate with them and we work with DOJ to enforce that law. But we do administer the anti-kickback statute, which is a criminal law. We offer advisor opinions, so if there are specific factual patterns that you're thinking about or business arrangements you want to enter into, there's actually a process where you can write into our office for a legal opinion. And if you receive a favorable one, you get prospective immunity under the criminal statute. So that's one mechanism. There are also opportunities if you think that there needs to be something broader, a safe harbor, for example. We didn't get to mention this, but every year OIG solicits input on new and revised safe harbors. It's part of an annual thing that happens at the end of December through the Federal Register, and there's an opportunity to submit recommendations there. So if there are categories or types of arrangements that you think need to be protected or at least considered, that's an option, and those are actually summarized in our fall semi-annual report. But even beyond that, you can reach out to me. If you want to come by later, please share your card with me. We're very interested in what's happening in the industry on these fronts and where there is at least a perception that certain things may or may not be allowed. Again, our job is to protect the program and to protect beneficiaries, and we want to do that by preventing the bad stuff, but we don't want to stand in the way of the good stuff.
And
thank you.
yesterday's congressional panel, day before, it's all blending together at this point. I know Stark and Stark reform was a topic that they did talk about. So, there are a lot of eyes looking at all of that complexity.
And thank you for coming to this kind of convention and presenting. I don't think someone in my realm would normally be exposed to this stuff, so thanks, and please continue to do so.
Absolutely, thank you.
Hi, I'm Darius Tahir. I'm a reporter with Politico. I may have missed this, but you discussed earlier that information blocking enforcement per se can't necessarily occur until you've written the regulations. I was wondering whether OIG has begun progress on rule writing for regulations on information blocking.
So the authority to actually issue the regulations goes directly to the Secretary. What I can tell you is that we're coordinating internally within HHS. We're aware that there are a lot of things that actually have to happen in order to implement 21st century cures, and we're working closely with everyone to make sure that it happens. This is a topic and an area that's been on our radar for quite some time. We actually issued a policy reminder a little over a year ago on information blocking, so it's something that we're focused on. It's something we're having internal conversations about, and we're working on right now.
I just want to say one thing about information blocking. It's certainly been in the press, and it's certainly very important. And I want to let everybody know that the ONC was obligated to fulfill their an obligation to report to Congress in April of 2015. So the ONC also has a document on information blocking. You know, they know about it. And they're also interested. If you sort of have an idea that somebody might be doing something, they're also collecting data too. So it's really from all ends. Also, I want to really thank HIMSS for starting. This is the first year we have a section on compliance and program integrity. Clearly, it's very important. So I think we really need to be very appreciative that this is certainly really important as far as EMR design and EMR management. And I think as people design medical records, electronic notes, clinical decision support, it's just so important to make sure that that note really reflects exactly what's going on with the patient. And as everything is, I say many times, if it's technically possible, it doesn't mean it's the right thing to do. And I'm thinking of copy and paste. I've read your audit on copy and paste. I have it on teaching slides. And, you know, you have to have strategic constraint. And, you know, I think it's always good, you know, we have all these people in these meetings. Well, who is your compliance colleague? And getting the compliance people in early, you know, having their opinion, it might sort of assuage some enthusiasm where you can bring people back to the center and design things so that it's really easy to do the right things right and it's really hard to do the wrong things wrong. So anyway, I really want to thank HIMSS, and I really want to thank you folks for you know, submitting this session. I mean, this is a really good thing for everybody and really for the whole health IT industry.
Gosh, thank you.
Thank
We
you,
want to
yes.
have you in for a public service announcement. Introduce some of our compliance videos. That
Yeah.
was just terrific.
We
Thank
really
you.
do appreciate the opportunity to speak here. It's really important for us to connect with this community, this industry, because more and more of our work overlaps and relates to health IT. I think we're at time, but I just want to remind everyone, please fill out your evaluations. You can do that using the mobile app. We really appreciate you coming to join us today. Thank you.